Dr. Nelson, you are too kind and too frivolous, and that is not what we shook hands on. Molly Gross, I told you I looked like one of your daughters. Oh, there you are. I look just like Anika, didn't I? Okay. I think it is tradition, appropriately at this point, for presidents in their addresses to acknowledge, thank, and honor their family, their friends, and their mentors. You can see that I asked my family not to come because Mimi and Hank are young. We are a soccer and hockey family now, and Jeff has to work, and I'm going to be at every minute of this meeting, so there was no reason for them to be here. They know I love them and appreciate them. I don't need my legal family here because I have my other family here. I have my Utah family here. I recognize that all of you are here. I recognize all of your support, and I think so much of every one of you more than you know. I have my Southwest Surgical family here. So many great friends. I tried to decide when I started coming to this meeting, and I think it was 1999, and I was seeing if I had ever missed a meeting, and I remembered every single presidential address but one. So I think I've missed one meeting since 1999. So you are my family. Thank you. That's why I enjoy this organization. I do want to mention, though, I truly believe that we have many, many mentors in life, and many different mentors in different stages in life and different needs for different mentors. But I want to mention two mentors in my life. There's a reason I asked Dr. Nelson to introduce me. It's because he is my mentor. I met Dr. Nelson in 1995, and since then, he has been my teacher, my division chief, my chairman, my mentor, my colleague, my friend, and now my neighbor. And every one of those relationships has been a privilege to me. When I met Dr. Nelson in 1995, I realized that he was the surgeon that I was going to be. He takes better care of patients. He is technically one of the most skilled surgeons I've ever been trained with. He is an extremely diplomatic leader. He is kind, and he is supportive. And I will continue to try to be like Dr. Nelson. And he has brought me through. I think my first presentation here was a presentation with him as my senior author. And so he's a mentor to me in Southwestern Surgical as well. So I wanted to mention my other mentor in Southwestern Surgical, and that's Ronnie Stewart. I don't know where that camera is. I don't know why Ronnie chose me to be the recorder that followed him, but it's been such an honor to try to follow his footsteps as a recorder. He was so committed to that position, and I tried to fill half those shoes. He is the face of this organization, and I think that one of the reasons that he chose me is because I was super feisty with him when he was doing an appendectomy on one of our residents. But the other is that he wanted to, it was a long time ago, he wanted someone to change the phenotype of this organization. He wanted a younger and a female person in the executive council. And so he asked me to represent that. And then he asked me to start a women's luncheon and so on, and I didn't. I wouldn't. Ronnie, your advocacy for the diversity and the phenotype of this organization by being a promoter and a supporter has changed the phenotype and the future of this organization far more than I ever could have. Thank you. It's not surprising with those two mentors that my topic is putting patients first. You start to think about this talk 2 years before, and you go to every meeting's presidential address, and it just makes you more nervous. You go back and think of the presidential addresses here, and it just makes you more nervous. And I wanted it to be something that was true to me. So I started thinking about what are the projects that I've done at the University of Utah since I've been there, despite oncology and HPV surgery. You aren't interested in that. And I realized that a lot of my career has really been trying to put patients first. When you Google that or you look up papers, there are a lot of definitions. This one was true to me, and I have a few more through the talk. But putting patients first focuses on the patient's personal needs, wants, desires, and goals, so that the individual becomes central to care. My goal for today is to talk about, did we get away from that? And I think we have. And how did that happen? And was it us or the patients or both? Do we need to change it? Should we be putting patients first? Are there benefits to doing so? And then talk briefly about 5 projects that I've been doing in the last 15 years that I've been at the university. We all went into this because we wanted to be a healer. A healer is a person who claims to be able to cure a disease or injury using special powers, a person or thing that mends or repairs something, and specifically someone who alleviates a person's distress or anguish. That's what we wanted to be. And that's been documented since mankind. Greater than thousands and thousands of years BC, there's been documentation of healers taking care of their own, and even surgeons, surgical techniques, providing care to their own people. In the United States, the First Nation cultures had their own healers and shamans caring for their tribe. It wasn't until the 1600s that described physicians were immigrating in from Northern Europe, mostly trained in England and Scotland. But they still were healers that would go to the patient, make house calls. Medical care revolved around the patient. The first hospitals opened in the United States in the 1970s. Interestingly, New York, New Orleans, and Philly all opened hospitals in similar time. And that's when medical care started becoming based around the institution and the providers and not around the physicians. With increases in technology, improved transportation, actually, an ambulance, that it was easier to get the patient to the hospital than the doctor to the patient. And then us specifically, we are sort of the violators and one of the leaders of why we've gotten away from the patient, because we need to be in the operating room. And so that's led to this sort of arrogant air of the physician. Patients have to come to the healthcare facility. Physicians are very specialized. Medicine and surgery particularly is financially rewarding, let's be honest. And there's always been a demand for more physicians and specifically more surgeons. So I chose this very arrogant pose of Christian Bernard, the transplant surgeon, or this very typical Hollywood picture of the nurse sweeping the surgeon's brow. We are very paternalistic to patients. And physicians have become so prestigious in the medical field. We have doctors' preference cards, and patients have to wait for us in the waiting room. How could I be wrong? I'm the doctor. A CEO of a hospital in Ohio quoted that patients are hostages of our healthcare system. That's not patients first. Our electronic health record history reflects that we've gone away from the patient also. This is a really fascinating paper that I found. It's worth a read, this paper. And it talks about how medical records started as just notes for the physician themselves, their own teaching, their own learning, their own notes on their patients. Toward the 1800s, more teaching others, teaching residents, and so on. But I learned from a really cool PBS history on the Mayo Clinic that it wasn't until the Mayo brothers hired an internist to join them, Henry Plummer. And Henry looked at the hospital and said, everybody has their own little notes about these patients, but we don't know what anybody's notes say about the same patient sitting in the same bed in the hospital. So let's sign them a number. Let's give them a medical record number. And that record will follow that patient, and every physician who sees it, it will be centered on the patient. Now, in the Flexner report in 1910, some of the points of the Flexner report sort of demanded this too, so it took off across the country. But it didn't span to outpatient and to other clinics and so on. It was only within the hospital. Jump forward 100 years, and CMS demands in the American Recovery and Reinvestment Act, we now have electronic health records. The goal of the health record is it would follow every medical visit, inpatient, outpatient, and it would capture every medical event that the patient had. How patient-centric would that be? It's brilliant. But we've failed. Successful health records are all billings-based, unfortunately. And what has happened, this paper concludes, in light of projected benefits, the actual performance of leading commercial electronic health records has been the subject of much criticism in literature by practitioners. I had 4 examples in here, and I shortened this, I just put 2 in. But this is an example of this billing-based note that is not patient-centric at all. It's not helping us look at the patient, and it's not helping us take care of the patient together. It's billing-based. This is a patient of mine seen within the last 3 months who was in the emergency room before they came to see me. And I've highlighted here, all the rest of the note is, yes, the 5 level 5 check boxes are all checked. The final diagnosis, obstruction, carcinomatosis, the plan, admit. No thought, no decision-making, no assessment of what was done, no differential diagnosis, nothing. But it meets the billing codes. Here's another example. It's a little bit smaller, you can't read it. All of the needed notes are in there. I have no idea what this note says. The diagnosis, abdominal pain or chest pain. Those aren't diagnoses, by the way. Those are symptoms. And I have no idea what the plan is in this note, but maybe patient is stable is the plan. That's what this note says. So this paper also concludes that physicians must not allow technology to devalue the doctor-patient relationship and the continuity of care in which the patient as a person maintains a place in the memory of the clinician and not just the computer. What about the patients? Maybe it's not just our fault, maybe it's not just the health record's fault, maybe they've left us as well. I was getting this talk together and one of our chief residents gave a fantastic grand rounds last year. I just texted her and told her I was giving her a little shout out. I highly recommend that you go to this link and watch this video. Her talk was postmodernism and its effect on medicine, and her interest was looking at complementary and alternative medicine. But she talked about in the beginning of her talk exactly what I was doing my research on for this talk, and I was like, oh, she just did all my work for me, awesome. Modernism is a period from the late 1800s to World War II. It was associated with an emphasis on rationality and search for knowledge obtained through scientific inquiry in a rational manner. Postmodernism is after World War II. People, became disillusioned and pessimistic with knowledge. They abandoned the search for truth, and they felt that the universal truth, or the search for a universal truth, is impossible. The philosophies of the postmodernistic person is anti-intellectualism, anti-science, and a belief in public knowledge. So this postmodernistic patient believes in cosmetic lotions and essential oils, non-regulated dietary supplements, gluten-free diets, and anti-vaccines far more than they believe in you. This is a study done out of the University of Utah where they looked at using electronic, email, iPad, printed patient education information, and then surveyed the patients and said, what information did you use and did you find most valuable before your surgery? And uniformly, the patients said the information they got from their family, their friend, or their neighbor was the most significant information that they got for their pre-surgery education, despite this study and effort to try to educate these patients. They don't believe us, the postmodernistic patient. The postmodernism patient would prefer to be seen by a chiropractor than a doctor because they put their hands on the patient more than we do. They spend more face-to-face time, and they let the patient do some of their own self-care and participate in their decision-making in their care. And that's what the postmodernism patient wants. A postmodernism patient would rather be rounded on by a robot. 80% thought the robot would give them better access to health care. 70% thought it would provide better information, and 50% said they would prefer the robot to their own doctor. The postmodernism patient wants to be able to pick and choose their health care, add complementary medicine, and be empowered. They want shared health care or shared decision making. Unfortunately, in all of that, though, we are inherently paternalistic. We take a patient to the operating room, put them to sleep, and they don't get to help with the decisions anymore. And many times we make game day decisions that we can't wake them up and let them help to decide. So inherently, surgery is paternalistic and is facilitating this broken relationship. So that's where we are. Patients don't trust us, patients don't want to believe in us, and we have gotten away from patients and our health record has gotten away from patients. So we need to go back to putting patients first. Is there a benefit in doing so? I think so. I think patients will benefit, I think the healthcare system would benefit, and I think we will benefit. So the patients first. Patient-reported outcomes have come along in the last 10 years. And I just have a few slides here. I could show you study after study after study, but I didn't want to torture you. That not only can patient-reported outcomes help patients and clinicians make better decisions, but they can enable a comparison of our performances and stimulate improvements in those services. So every study, and I just have a few references at the bottom of each of these slides, but every study shows that if we address what the patients want us to address, not take the tumor out, but make sure that they have a colostomy that functions well, or don't have a colostomy, or don't want a ventilator, or don't go to a rehab facility afterward, don't facilitate their financial stresses. If we address all of those things, the human being, if we put the patient first and not just take out the cancer, the patients do better. We decrease their morbidity, we decrease length of stay, we decrease readmissions, we improve their perceptions of our care, we improve survival, and there are even studies that would show that we improve cancer-specific overall survival. And we decrease discharge to long-term care facilities. If we coordinate the holistic care of the patient, is putting patients first. What does that mean? It means controlling their comorbidities, reconciling their medications before our surgeries, increasing their physical abilities, stopping their tobacco use, addressing their financial and social stresses, and improving our efforts at education. That's putting patients first. If we do all of that, we improve their engagement, we improve their education, we improve shared decision-making, and we improve their satisfaction with more efficient care. These multimodality prehab interventions have been shown, same things as before, to decrease morbidity, improve health outcomes for the patient psychologically and physically, and decrease readmissions. So the patients clearly would benefit if we would take care of the whole patient. What about the system? Is the system going to benefit? Should they be investing in this? Well, we looked at our own institution and found out that when we invest in this, we were able to decrease our surgery cancellations, length of stay, again complications, which is expensive for the healthcare system, improve our O to E billing ratios, and improve our utilization of resources and cost containment. This is a paper that reviewed a lot of papers looking at preoperative anesthesia clinics and again showed the same things: decreased cancellations, length of stay, medical issues or comorbidities well managed, financial benefits for the institution, mortality improved, decreased surgery delays. So we looked at our own. At the University of Utah in the system, outpatient and inpatient ORs, we have about a 2 to 5% cancellation rate, mostly outpatient, sort of urgent, quick cases. It's about the national standard, and that's a small percentage. That means that 95% of our cases go on as scheduled. But what we found is that there actually is a significant cost associated with that. Most of that is due to the downtime, FTEs, RN, tech, CRNA, residents, anesthesiologist, surgeon not being utilized, but also costs of the room, instruments that are opened, and so on. We found that we probably lose $8 million a year with a 2% cancellation rate. And that doesn't include missed opportunities like timely surgery, alignment of personnel, efficient utilization, and that doesn't include professional fees. So more than $8 million of cost lost to the institution with only a 2 to 5% cancellation rate. So we looked at it and said, well, what's causing these cancellations? What can we do to fix it? 44% of our cancellations were due to just a poorly managed comorbidity or a patient that wasn't educated or wasn't oriented where they needed to be when they needed to be there. And the majority of those could have been fixed by having an organized preoperative clinic. So we must put the patients first. By putting the patients first, we're going to save resources and finances for the healthcare system. So what about us? We wanted to be a healer. That's what we did. I found this website when I was doing this research, and I thought it was so charming. College of Medicine in Phoenix. Do you want to make a difference in people's lives? Does having a positive impact and the ability to help others drive you? If you answered yes, then you're on the right track. Medicine is a career driven by service, and you are tasked at putting others first. But that's why we did this. This is a study out of Sierra Leone, actually, but it looked at studies from Europe of why did people go into medicine. 75% said they wanted to help people, and another 70% said they were just interested in medicine. That's why we did this. So if we're clicking the electronic health record or getting bogged down in health CPOE and administrative issues, and we don't feel like the patients are melding with us and we don't feel like we're taking good care of the patients, we are going to burn out. We are healers. We want to take good care of our patients. Better patient satisfaction improves our outcomes and our own outlook. I had the privilege a month ago to go to the AHPBA, and Barbara Bass was giving a wellness or a balance talk there, and the title of her talk is We Must Do Well, We Must Be Well to Do Well. And I was listening to her talk and thinking about this talk and thinking the opposite is also true. We must do well to be well. If we take good care of our patients and if we make that bond with patients again where we can feel like a healer, we won't burn out. And there are lots of papers that show this. Most of those papers are concentrated on the electronic health record, which sort of sounds like it's become the punching bag of my talk, and that's not my intent. But you've probably seen on NPR, this just came out, there is a physician who wants to remain unnamed. He's from upper northeast and has started this handle, this Twitter handle, Epic MR Parody, and writes sarcastic tweets on an almost daily basis. This is one I just found last night. I have mixed feelings about tablets. Sure, he's gazing at the screen like he's supposed to, ignoring the patient, but this could easily be turned around. There's potential for bad outcome here. All of these tweets are super sarcastic and supposed to be from the perspective of Epic, but it's providers expressing their frustrations with this, where we are in health records, and where we are getting away from patients. The AAMC put out an announcement in 2018 that shows that there's a significant physician shortage predicted, as there always has been. Half of that is because maybe fewer people are going into medicine, but the other half is people leaving the field. And they cite electronic health record as a major part of the problem. Almost 60% said the health record needs a complete overhaul, and 40% said they see more challenges than benefits and are leaving their careers. Physicians who use the electronic health record and CPOE are less satisfied with the amount of time they're spent on clerical tasks and are at higher risk for physician burnout. The other paragraphs in here say that if we were just getting back to taking care of patients and being healers, our burnout rates go down. So, thank goodness, Crossing the Quality Chasm came out. 2001, To Err is Human in 2000, reports from the Institute of Medicine Committee on Quality in Healthcare, and these reports said that our quality outcomes in the United States are not adequate. Our quality is not good enough, and they cited 6 main aims that every healthcare system needs to target to improve our quality, and one of them is patient-centered care, that we have to be putting the patients first to improve our care. Putting patients first, really putting patients first, means ensuring that patients will have continuity of care with healthcare professionals whom the patient knows and trusts, shared decision-making, an agreed plan, and transparency in their plan and maybe even their costs. Shifting away from a provider focus to a patient-focused care takes sustained effort and endorsement from a healthcare organization. Elemental to the delivery of patient-centered care are structures and processes in the healthcare system. And so I've been privileged in the last 5-10 years to have my healthcare system be really quite supportive and really driven in quality care. And so we all got lean trained, and one of these projects was my lean training project. And it's really been fantastic that when I ask my institution for another FTE to do one of these projects, I've really gotten a lot of support. And so if you go back to that, to be patient-centered, it takes an institution's investment. These are small projects, but I've been privileged to try to work on these projects. The first one I want to highlight, and it's just 5 projects I'll highlight fairly quickly here. The first one I want to highlight, all of you have done, and this we did 15 years ago. But it's important, and I want to congratulate all of you when you've done this, that I think this is putting patients first. So when I first started my practice in 2003, and young people don't do the math, 30% of my patients, 30 to 40% of my patients travel from outside the state of Utah, travel from more than 2 hours away just to come to a clinic visit. And it was a classic, they were hostages to my clinic. It was a classic, they would come and see me. I would say, yep, you need to see me, but you need to see medical oncology next, and you need a biopsy, and you didn't get your MRI. And so we'll put the MRI next week Thursday, and the biopsy will be next week Wednesday, and the medical oncologist will see you in 2 weeks. And they were hostages of my clinic. That's not patient-centered care. So we sat down with our team. Who picked I Can't Get No Satisfaction to be our patient hold music? We sat down with our team, many of the providers, and our patient coordinators. We hired new patient coordinators. People call them navigators. Everybody has a different definition of navigators, so we call them coordinators. And we sat down with the NCCN guidelines, because I'm an oncologist, and we decided what should happen to these patients before they even get an appointment. We should gather all their records, and we wrote these algorithms. And if a patient with esophageal cancer doesn't have a PET scan, my coordinator orders before they ever come to see me. If there's no biopsy, they order that before they ever come to see me. They have a pancreas mass or a cyst with no EUS-FNA, that's ordered, and then it's coordinated that they'll get the EUS-FNA on Monday, they'll see me on Tuesday, they'll see medical oncology on Wednesday, and it's ordered. We tried to have a goal of 1 stick. Patients don't go to the lab more than once. And all the necessary providers' visits would be coordinated within 1 to 3 days. Patients would have subsidized housing through the hospital. Social work would meet with them and help coordinate their travel and their visit and their stay. And they would be seen in 1 visit instead of driving back and forth from out of state 5 hours, 3 different times, 4 different weeks in a row. In doing this, we significantly improved efficiency. We shortened our visit time and our travel time for patient. We significantly reduced redundancy in labs and imaging. We improved our EPE scores. And an unexpected outcome is we improved referring provider satisfaction. The patient sent from someone in Montana went back to their doctor and said, wow, that was really efficient. Thanks so much for sending me there. And then that person sent us more patients. So that was an unexpected outcome, but has been really noticeable when we get feedback from providers that patients appreciate this more organized care. And I think that more organized care is putting patients first to the best that we paternalistic surgeons can do. So my next project was doctor's preference cards. And this isn't putting patients first, but this was taking physicians out of this erudite spotlight that for some reason made me crazy. Maybe it was the girl in me. Doctor's preference cards is what our hospital calls the guide to what's going to happen in the operating room. They're inaccurate. They increased the time and cost and product waste because they were inaccurate. They were on paper. When you went from one operating room at the Huntsman to the other operating room at the university hospital, they didn't follow each other and they might say different things for the same operation. They had significant inter-physician variability. So we had 10 physicians who would do a lap appy at night. They all had a different doctor's preference cards because it was the doctor's preference. It was unclear of how they were updated or how often they were updated. This led to significant variations in costs, product usage between different surgeons, supplies, non-transparent to the users and to the people who are opening the supplies in the room, and no accountability to us or the ancillary staff. We had no idea what we were opening. We had no idea how much everything cost that we were opening. We had no idea how much that bottle of wine was and that we couldn't afford it. So we implemented a change. We made our doctor's preference cards electronic. We call them DPCs. We can't get rid of doctor's preference cards, I guess. So we call them DPCs. We changed them to be electronic, and we did a project with cost transparency as much as our contracts with industry would allow us to do so. We let the staff know how much is that stapler load, how much is that device. We let the surgeons know. We standardized them. We sat down with all the surgeons who did appies at night and all the surgeons who did choles at night and said, could we 95% get to the same operation? So no matter what, at 2 in the morning, they know what to open. They don't have to go and see that it's John Smith or Susie Jones. They can just do an appy. So it can be patient-centered and not doctor-centered. We had an education process. We had a debrief process, and we have an annual system of reviewing these cards. And then for our lean project, we looked at it. And for lap choles, we removed 20 items from different doctors' DPCs to get it down to a 95% of it, it's all the same DPC. And we moved 30 different items, products, opened, industry, disposables, from the appy DPCs. And in total, that was almost $400 and almost $1,500 in total of all those DPCs. If we average that across now the new 95% DPC to all the providers, we had a cost savings of over $100 for any single lap chole and almost $250, $300 for any single lap appy. And if you annualize that and said maybe we did 100 of those a year, which I'm sure many of you do way more, that's almost $36,000 just by getting rid of extra things and getting rid of having the cards be about the doctor and not about the patient or the procedure. The financial impact, 30% reduced costs from appies, 25% reduced costs of lap choles. Patient impact, more standard care, annual reviews to best practices for the patient, and more efficient care. So at 2 in the morning, the team's not running around opening 3 different things. Oh, that's the wrong doctor. Delay the case, open 6 more things. No delays, no waste, because the DPCs are 95% correlated. Those are old projects that we've worked on, and so these are my newer projects that I'm working on, and this is the one I'm most passionate about at the moment. And this is a modified preoperative clinic. I don't know if there's any candy in the machine, if there's a candy machine in the building. So we need to we need to prehab these patients for surgery. And we have this surgery strive clinic that I'm really excited to say is going to take off. We've been piloting parts of it for the past 6 to 12 months, but we just got the thumbs up financially, space-wise, and everything to take this thing off in July of this year. We like to describe that surgery strive is strong for surgery and ERAS combined on steroids. And so STRIVE stands for strong for surgery or strengthening, enhanced recovery, an informed patient, value-driven care, and an exceptional experience for the patients. And this surgery strive, the concept of strive will be all phases of care of the patient. And so ERAS is kind of the peri-hospital care. We ultimately plan to have apps and email notifications and education to make sure the patient's on the right track and managing their wounds. But this project in particular concentrates on the prehab or the pre-op care and a multi-ancillary or holistic care of the patient, looking at reconciling their meds and their comorbidities, case management involved with any patient. Any patient who has financial stresses or concerned about their insurance can see financial services. Endocrine will see every patient who's at risk for being a diabetic. Smoking cessation, nutrition, anesthesia, OT, PT, end-of-life discussions, etc. And the idea is that it's a drop-in clinic. Anesthesia or someone in the anesthesia team, so we've written an algorithm, and maybe they'll see a nurse, maybe they'll see an APP or a resident, or maybe they'll see the attending physician, depending on how they upscale in the algorithm. But they will be seen by someone on the anesthesia team. And then they will be seen by all of those coordinated services. So we'll refer them from our clinic, the consults will be coordinated, and the referrals are based on a patient assessment, as I'll show you in just a minute. But the concept is that it will be all surrounded by putting the patient first and be centered around the patient. The Surgery Strive Clinic, as I mentioned, is going to have all these services, but they're going to be same-day appointments, and we're going to assess the need for these appointments by questionnaire. So we've changed our new patient visit form to include questions that these teams have given us, and this is not meant for you to read all of these, but, you know, do you smoke or not? Do you use tobacco products or not? That's easy. But dietary says, you know, have you gained a lot of weight or have you lost a lot of weight? That's a red flag. Can you walk? That's a red flag. Do you have any questions about your insurance? Do you have any concerns about your insurance might not pay for this? Do you have any financial stresses? That's a red flag, then financial services gets called for that patient. And this is just part of their new patient form. So our process is every patient gets our new patient form. They all get it electronically with an opportunity to fill it out electronically and send it back to us electronically, and it dumps into our electronic health record. About 70% of our patients still do it on paper. But we'll get there. But those questions are embedded in that new patient form. If I see a patient in clinic and say, yep, this one's a pre-op, my clinical coordinator sends them to the drop-in clinic. The drop-in clinic calls all of those red flags that got flagged, financial services, smoking cessation, etc. They come to the patient, anesthesia sees the patient, they educate the patient, they suggest interventions, and then they follow up with the patient in the few weeks or days before surgery and continue to do interventions and education of those patients to prehab those patients for surgery. Oh, Heather said, don't use the rollerball. So all the patients, all the patients are pre-op by the anesthesia team. They have multidisciplinary assessments. They have proved education and engagement, which is what these post-modernism patients want. Engagement and investment and feel like they're able to do their own self-care. And then it's a drop-in scheduling. And a lot of administrators and some providers were frustrated with my vision of that at first, but as I surveyed my clinics for about 3 months, I saw that all my scheduled pre-op appointments, 40% of them turned out to not actually be pre-op appointments. Of my new patient visits, 60% of them turned out to be, oh, you need a surgery, that's all you need, let's get you on the schedule. And 40% of all of those patients were from more than 5 hours away. So the drop-in model just makes more sense. We call it the Great Clips model. And we've modeled it after Great Clips. There are days when we need to have it fully staffed. There are days when maybe only one patient will come in, depending on how many providers are in clinic, depending on Christmas, spring break. And so we've sort of modeled it after. We staffed the FTEs with expected volume of people. And we're going to go full, I told you this summer, so maybe I'll give you a follow-up and let you know if it's worked, but we're really excited about this. We hope that it's a success, and I think that this is absolutely patient-centered. I'm really excited about it. The next two projects that I am going to talk about have just been born, and this one is an iceberg off of the last project, that as we were working on this, we realized that every single clinic has their own version of the new patient form. You all remember from your first day of medical school that 80% of that form is exactly the same. Family history, social history, meds, allergies. We ask the same question over and over again. And every week I see a patient who, just the other day I saw a patient who saw urology last week, medical oncology yesterday, and heck, if my clinic didn't hand them that gosh darn new patient form that they just filled out 2 times in the previous week. They've already filled that same exact form out, and they tell you they are not happy about it. And we have an electronic health record now. So when urology dictated their H&P or the MA put that patient in clinic, that stuff was already in our health record. It's already in there. We need you to fill out this form again, and this time don't skip all the embarrassing parts. So our goal is to make an institution-wide single new patient visit form. If you have a medical record in the university's electronic health record system, you will never get mailed a new patient form ever again. That's my vision. We had a meeting just the other day and said, well, maybe if they have a pyloric stenosis and now they're 70 and they're having a fib, maybe they should fill it out again. We're going to decide on the timing. Maybe 10 years is going to be our cutoff. But the goal is that it's in the electronic record, so the patient will still get a new patient visit form, but it will be theirs, and it's already filled out, and it says, this is what you filled out 3 weeks ago for urology. Do you have any updates or changes? And they will not necessarily ever get that form again, except we recognize that about 20% of that form is different for every team. If someone's been having some weird rash, I've never asked them that, and I don't care, unless they have a pancreas neuroendocrine tumor. When someone has 6 children and started their menses here and had their menopause here, I am not interested. The breast cancer team is profoundly interested. So that's what we're calling the 20%. So patients will get your 20% specific form. So they're still going to get a form from all of us, but they are appreciative that that's 1 page long instead of 15 pages long of the same information that they just filled out for urology last week. So the last project that we've just started, and I am actually really excited about this project as well, is that I told you we have these new patient visit coordinators, or navigators, some people call them. They do our patient intake algorithms or pathways. I started to realize, though, that they were starting, in my team, I had 2 of them, and I kind of realized that one was starting to work for medical oncology and one was starting to work for surgery, and they were becoming doctor-centric again. We have got to put patients first, and my poor team hears me say this all the time. And then, not putting patients first, as soon as medical oncology finished chemo and they needed their 5-year surveillance, the patients kind of got lost. And they would order an MRI in 3 months, and I would order a CAT scan in 5 months, and I'm not exaggerating that I'll have a patient from Wyoming drive 5 hours to see me in clinic and say, well, when I saw Dr. Weiss last week, I'm like, you saw Dr. Weiss last week? You didn't need to come today. It happens all the time. So we have now a new project where my patient care coordinators work for the patient. They don't work for us. So when you call and try to get an appointment with any of us in the GI oncology team, you get assigned one of our 3 patient care coordinators. If you get assigned to Rudy, Rudy is your coordinator for the next 5 years of your cancer journey. Every time a doctor says, I want you to get a lab, I want you to come for a visit, I want you to get imaging, you call Rudy and say, when is that scheduled? And Rudy makes sure that there's not a conflicting lab, conflicting imaging, or conflicting visit, and coordinates them. And we do the same. When we have finished our first treatment course, so when they've finished their 3 months of medical oncology chemotherapy, the medical oncology team calls Rudy and says, we're kicking them out of our acute system. They're a post-op, I've operated on them, and now they're done, and they need to go into their surveillance, and Rudy, will you please coordinate it? And we've written algorithms by the NCCN guidelines, and Rudy coordinates that care for the patient for the next 5 years. So the coordinator works for the patient because we're trying to put the patients first. The university has supported this. They've increased 1.5 FTEs for our group. We've figured out in Epic how to make this work. Our coordinators have their own patient lists. We've figured out how to figure out in the patient's chart who that coordinator is. We've added them to the care team providers. We've piloted this with a few physicians so far. We need to continue educating and change the culture of our team, but this is working, and it's going to be really cool, and patients really appreciate this. So these are the 5 patient-centered protocols that I've done: pathways, get rid of doctor's preference cards, centered pre-op clinic, a single new patient visit form, and patient care coordinators working for the patient. I recognize that they're very small steps. I recognize that I did not address the electronic health record frustrations at all, but maybe I've helped our frustrations because we've made the patients be more important to us. But I will emphasize again that quote from that paper, that shifting away from a provider focus to a patient-focused care takes sustained effort and endorsement from your healthcare organization, and I've been privileged to have that endorsement from my organization. Putting patients first heals the postmodernism relationship, makes patients the center of their healthcare system, which the postmodernism patients want, improves coordination of care from all of us, and improves our efficiency, improves their education, their satisfaction, improves our career satisfaction, and probably has some financial return from our healthcare system. I can't close this talk without some thank yous. I keep emphasizing this, but honestly, when you're in this position, you realize how much these people do for our organization. LP, et cetera, Margie and Jill as the leaders of that organization and their fantastic team really deserve a round of applause. Thank you. And I said this morning, but I'll say it again, that what happens behind the scenes is that awesome group back there, Chris and Heather Sherman, and really, again, super support of this meeting for many, many years. This executive committee is an amazing group of very kind, very thoughtful, and very committed to this organization group of people. And I really thank them for all the work that we've done in the last few years together. And you're stuck with me maybe for a couple years, but really a fantastic executive committee. Thank you to Dr. Britt for joining us. It's a privilege to have her visiting us, and it was a privilege to go to her meeting. I want to thank the council, all the counselors at large, the committee chair people, the committee members. I knew I was going to forget someone, but I want to thank all of the invited speakers. Spending the time to put together a long talk on a volunteer basis for this meeting is fantastic. I want to thank the moderators and the discussants and for reviewing those papers, the people who are committed to the oral boards review, and the program committee for reading over 200 abstracts and choosing the top 30 for such a fantastic scientific sessions that we've had. And of course, we don't go anywhere in this organization without the program chair, and Dr. Pickron has really done a fantastic job at putting this meeting together, and I'm appreciative of all the hard work that he's done in preparation for this meeting. We'll adjourn now. I appreciate your attention. It's been an absolute privilege to serve this organization for the past several years, but this past year in the honor of being president, it's a privilege to have this lectern. Please join us for the e-poster session, and don't forget to come to the cocktail reception at 6:25 tonight. Thank you. You're very kind. Thank you very much.
So, I don't know why I'm doing this, but here is a medal on a ribbon that says 2018-19 Courtney L. Scaife, MD, President, Southwestern Surgical Congress. Congratulations. Great talk.
Thank you so much.